Okay, welcome everyone to the value of biomarker testing, case studies across multiple institutions. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, the VP of Program Services, and I would like to introduce our presenters for today. We would like to thank Bayer, Daiichi Sankyo, Foundation Medicine, Genentech, and Guardant for their unrestricted educational grants for today's webinar. And now I'd like to introduce our presenters. Dr. Prapasorn Thirasaster is a postdoc fellow at the University of Texas MD Anderson Cancer Center. She's practiced as a medical oncologist in Thailand for 2 years before joining the postdoctoral research program in MD Anderson Cancer Center under Dr. Nita Somaiya, an associate professor of sarcoma medical oncology and deputy chair in Division of Cancer Medicine at MD Anderson, as her mentor. Currently, her research focuses on sarcoma, especially liposarcoma and GIST, and she is engaged in both clinical and basic science research projects. Dr. Steve Bialik is a second-year hematology oncology fellow at Jackson Memorial Hospital and the University of Miami Sylvester Comprehensive Cancer Center. He completed his internal medicine residency within the University of Pennsylvania Health System before working as a hematological malignancy hospitalist at the Hospital of University of Pennsylvania. He is now completing his oncology training with a focus on solid tumor malignancies, specifically soft tissue and bone sarcomas. His research interests include hereditary cancer predisposition syndromes, circulating tumor DNA, and its role in guiding targeted therapies, and the role of DNA damage repair pathways in sarcomas. Dr. Dixon Duran is a clinical fellow, currently completing his medical oncology fellowship in the Molecular and Genetic Epidemiology of Cancer program at Vanderbilt Ingram Cancer Center. He works in the laboratory of Dr. Ben Park, where he uses a basic science approach to interrogate how mutations that regulate genetic machinery can be manipulated for therapeutic benefit. He also uses genetic profiling to determine which tumor mutations contribute to chemotherapy resistance in sarcomas. And clinically, he collaborates with Dr. Elizabeth Davis and Dr. Vicky Keedy at Vanderbilt to characterize mutations in patient tumor samples in GIST and other sarcoma types that may provide new therapeutic targets. He hopes to pursue a career focused on GIST and other soft tissue and bone sarcomas once he completes his formal training. And without further ado, I would like to turn this over to Dr. Thirasaster to begin the first case presentation.
Thank you so much. I really appreciated the opportunity to present this case to you. She is a patient of Dr. Nita Somaiya at MD Anderson Cancer Center, and Dr. Nita Somaiya will be with us as well to discuss this case. Okay. So the patient is a 49 years old woman with history of diffuse large B-cell lymphoma treated with chemotherapy and autologous bone marrow transplant. Her lymphoma has been in remission for 6 years. In March 2020, she had abdominal pain and swelling. PET and CT scan at that time showed 13 centimeter mass at left mid-abdomen, rising from stomach. No other abnormality was seen. The fine needle aspiration of the mass was done and positive for GIST, having 1 microtic figure per 5 square millimeter. The diagnosis in this case was unresectable gastric GIST without evidence of metastasis. So the treatment plan is to treat with systemic treatment with imatinib, 400 milligrams per day, in order to shrink the tumor to be able to do surgery afterward. However, 3 months after treatment with imatinib, the tumor has increased in size, and new liver lesion was also seen. At this point, the disease had shown progress on imatinib, so the patient presented to MD Anderson for second opinion. So at MD Anderson Cancer Center, the mutation analysis was sent and reviewed PDGFR alpha exon 18 mutation D842V. Also, the liver lesion was also biopsy and negative for malignancy. So there is no definite evidence of metastasis. So she was changed to Avopritinib 300 milligrams per day since August 2020. After 4 months of Avopritinib, her disease responds well to Avopritinib, as you can see in the picture. The mass has reduced in size, but she had to stop the Avopritinib due to the toxicity since January 2021. The toxicity was the fluid retention, significant requiring pleural catheters and paracentesis. So we had to stop the treatment. However, her disease is still good and she can undergo the surgery in June 2021. And before the surgery, we have laparoscopic exploration to test the ascites to be negative for malignancy before we do the surgery. And since then, her disease is still no evidence of disease, and we still follow up her disease until now. So the next part will be the discussion. I will send to Dr. Snita Sumayan.
Yeah, well, good morning, afternoon, everyone. So one of the things I just wanted to highlight in this patient, so when she first presented, it was a localized mass, though it was huge, being 14 centimeters, and hence was not considered easily resectable. It would have required a complete gastrectomy. So the patient was started on imatinib, which is the most commonly used neoadjuvant treatment. But what we want to try and highlight here again is the importance of mutation testing. So before you start any form of oral therapy for GIST, or at least, not before you start, but at least there should be an intention to send off the mutations as you are starting imatinib, because there is a small percentage chance that the patient's primary mutation might be resistant to imatinib. Just as what happened in this case, where the patient actually was very surprised, the local oncologist was surprised when she progressed, because it's not very common to progress on imatinib. But then had a great response to Avopritinib. But again, another complication in the case was she developed some toxicities, which was significant fluid retention requiring, catheter drains in her bilateral lungs and multiple drainage of fluid from her abdomen, so much so that it was depleting her protein. So her nutritional status was deteriorating. And the surgeons were always a little worried that she might have peritoneal spread with metastases, because her CT was always read as some thickening in the abdominal area. But the outcome was very good, because this drug works really well for PDGFR. So she responded well, and it responded well enough that we could actually take a break from the treatment in order for her body to recover, her nutritional status to improve, and then she underwent a very successful surgery. So just a few highlighting slides here. Again, this is just a slide that denotes the primary mutations that you see most often in patients diagnosed with GIST. So majority, 70 to 80% of mutations will be in the gene KIT, and there are various locations in that gene. So you have a long gene, and there are various exons, what we call locations or points on the gene, which are abnormal. And as you can see, exon 11 here is the most commonly mutated and tends to respond well to imatinib. And then exon 9 is the next most frequent, and then exon 13 and 17 are low frequency for a primary mutation. Primary mutation, again, means the mutation that was first, was the inciting factor or the first mutation in your GIST tumor. If the KIT mutation is absent, then you might have a PDGFR mutation in 5 to 10% of the cases, and that is most commonly seen in exon 18. And these exon 18 mutations, majority tend to be resistant to imatinib, which is where this new drug that was approved, I think, in 2020 has made a significant difference. Next slide. So this is just, as you go to your, oncologist, or if you've been diagnosed, this is what they generally do to diagnose the mutations. So since GIST is majority driven by KIT or PDGFR, you could do point mutation testing, which is relatively cheaper and faster, where they do a PCR-based assay to detect for abnormalities in these two genes. Now, if you do not detect a mutation in KIT or PDGFR with this limited or targeted panel, then you can always do an expanded panel, which is, a whole, what we call next-gen sequencing panel. There are a variety of companies that do this, a variety of, or multiple academic centers also have their own panels internally. So that would detect around 500 odd genes that are commonly mutated in cancers that include KIT and PDGFR to detect what might be driving the GIST if we don't detect it in targeted panel. Next slide. So this is, again, I'm not going to go through the details because we have other cases to go through, but this is just highlighting that even though when you look at the middle section, which says resectable disease, and we normally have treatment with imatinib in the either neoadjuvant, which means prior to surgery to try and shrink it, and then even after the surgery, if the risk of recurrence is high, you get what we call adjuvant imatinib. Again, this is with the caveat that before you start any TKI, it's important to test for mutations, because just as we saw with our patient, if you have a difficult to resect GIST and you're planning to start imatinib, you might start them on imatinib, but definitely send off mutations, because if you're among the 5 to 8% that have this mutation, then imatinib is not going to do anything and you'll be wasting precious time. So that's what I wanted to highlight in this slide, and then the rest, of course, this slide goes through the different lines of therapy available for patients who don't have or who have unresectable GIST. Next slide. And this is the study that got Avopritinib approved. I won't go through too much detail here. It was presented by Dr. Heinrich, and this is now published and approved. So this, Avopritinib was brought into clinical testing because the preclinical data looked really good, and that the blue 285 there is actually Avopritinib. That was the initial name allotted to it. And as you can see, when you look at the last column, which is the PDGFR D842V mutation on exon 18, the sensitivity to that drug is very high compared to all the other drugs. You can see imatinib really doesn't target PDGFR D842V. So that drug and this crenolanib were the only two with some activity against this mutation. Next slide. And you can actually, this was the design of the study where patients with advanced GIST had to get mutation testing, and they were put into different cohorts if they had PDGFR mutation or if they had a KIT mutation, and then they were treated with Avopritinib. Next slide. And this is the data that got it approved. And again, what we're looking at is each line or bar represents a patient, or patient's rather tumor dimension. So each bar is a patient, but the length of the bar is at the 0 mark is where they started out with initially when they started on the study. So that is the entry point when they started Avopritinib. And as you can see, almost all patients, barring these two, with an exon 18 mutation had reduction. So this is on the y-axis, you see is the maximum percentage reduction from baseline in the target lesion diameter. And you can see, except the two, all other patients had a reduction in their tumor size. So the response rates really was a pretty high, 95% or 86% overall response rate, but 95% patients actually had reduction in tumor. And complete response was seen in 3 patients. So it was very impressive for a mutation type which did not have any treatments prior to this. Next slide. Again, this just highlights in different lines of this is for PDGFR D842V by line of therapy. So it didn't matter because no drug was available prior to this. So patients had seen other treatments, but whatever line you were treated in, once you got the Avopritinib, you responded. Next slide. I won't go through this, but it shows that Avopritinib had some response in patients who did not have D842V mutations as well, though it was not as impressive as those who had the D842V. Next slide. And this is just highlighting because safety information is always important, as it came into the limelight with our patient, where we were scratching our heads with this amount of edema. She also had some prior to starting Avopritinib, but what was really telling is when she stopped the Avopritinib, all this fluid retention went away. So as you can see, the safety data, when it's presented, what gets really highlighted is this drug is associated with cognitive effects, which is really characterized by a little bit of mental slowing that can get very significant if it's not caught early. So on this particular drug, assessing the patient and asking the caregivers of how their mental status is, are they getting more forgetful, are they slowing down, is important, because you could dose reduce these patients and still get a response and actually improve that side effect. But our patient didn't have the cognitive side effects, but she had pretty significant edema. And as you can see here, there is a little bit of periorbital edema and peripheral edema that was captured on the study, but some patients can have unusual fluid retention, as can be seen with imatinib as well. So that's it, and I will leave the rest for the question answer session. I don't know if you're doing it after each case or if you're going to wait till we're done.
We're going to wait till the end of all the presentations, but thank you very much for presenting this case. It was excellent and definitely demonstrated the importance of getting mutational testing. So next we're going to move on to Dr. Bialik, if you don't mind sharing your screen.
Sure. Let me know if I'm sharing correctly. Can we see the slides?
Yes.
Perfect. Great. So thank you for the opportunity to speak here. My name is Dr. Bialik Steve. I'm one of the fellows at the University of Miami here in Sylvester. This is not a virtual background. Actually, this is truly me, as we discovered before, here in South Florida. And so we'll talk exactly like what you guys in Texas just talked about, and the benefit of biomarker testing in our patients with sarcoma, which is kind of this emerging field for patients and therapy decision-making. And so a little bit of background for everyone on the call, a little bit about sarcoma, in that it is a rare cancer, which affects about 1% of all adults. And because sarcomas come from connective tissue, there's over 150 different types of sarcomas. And so there is a need for all of this ongoing research to more clearly understand kind of the genetic background and the genetic makeup of these sarcomas. And so this is why I think this is great that we're doing these case presentations to highlight the value of the biomarker testing that we do, to see how we can pick therapies that may be more targeted so that we can come up with more effective treatments for our patients and less toxic than the systemic chemo we currently offer. Just a quick overview on GIST before we get into our case, that it is the most common sarcoma of the GI tract and does have a high frequency of metastatic disease or disease that starts in one place, spreads somewhere else. And we treat these with drugs called tyrosine kinase inhibitors, or TKIs. And what we're focusing today on is these gene mutations, which can typically drive how we manage the therapy or which drugs we pick for patients that have these mutations that we can pick up on the different types of testing that we have available to us. And the folks at MD Anderson talked just about before the NGS, the next genome sequencing or next gen sequencing that we can do from the tissue, the tumor itself. And there's a newer, more emerging model called CTDNA, or Circulating Tumor DNA, which we'll talk about today, and kind of helped our patient in terms of how his response to his tumor was. But there are some of these mutations we can pick up that I list here on the bottom that have certain drugs that work a little bit better or have some more sensitivity to different mutations that we can detect on these molecular profile studies. So the two that we mentioned, one is from the tissue itself. This is a next-gen sequencing, or NGS, from the tumor itself. And this is a very comprehensive and effective method in identifying the KIT and the PDGFR mutations. And most patients with GIST get this frontline or initial testing on their tumor, and later down the road if they have a metastatic site or a recurrence. But it is a pretty invasive procedure, requires a biopsy and enough tissue in the lab to study and look at it. And the turnaround time is lengthy when we compare it to things like CTDNA, which is this newer emerging resource that we have, where the tumor itself can leak some of its DNA into the bloodstream. And this allows us to take a rapid blood test, not necessarily a tissue biopsy, but a blood test like you would get in a lab, that can sometimes be used to check the DNA of the tumor if it's available in the bloodstream. And this model has been shown in different cancers like lung and colon cancer to be effective. And 2 years ago, there was a study that showed that in metastatic GIST patients, what we call the high predictive value, or a strong correlation of this CTDNA value in patients that have metastatic GIST. And again, this will help us define the right choice of therapy, or an adequate or advantageous therapy, or may, in patients just like our case. So here we'll talk about a patient that we treated here. This is a 55-year-old gentleman with a metastatic or stage 4 gastric GIST, for which he had metastatic disease in his liver. He was diagnosed in 2009 initially as a stage 3 tumor when he was just 46 years old on an endoscopy. Initially started on Gleevec, the first-line treatment for GIST. He had imatinib, and for about 2.5 years, he had a good response. Eventually, though, he had some progression of his tumor, and they increased the dose of the Gleevec after he had surgery. But maybe 6 months after that, he had some new disease in his abdomen, and so he started a drug called Sutent, or sunitinib, and had some toxicity or side effects. He had some fatigue and rash, and so that med wasn't working well for him, so he switched to a drug called Stivarga, or regorafenib. He had some progressive disease a couple months after that, and so the dose was actually increased, but he had a rash on his hands and feet and some diarrhea, and so the dose had to be taken down again. Again, this drug didn't work after a while, and he had some progressive disease and started another one of those tyrosine kinase inhibitors, TKIs, called Votrient, or pazopanib, only briefly because he unfortunately had progressive disease again. Ultimately, he had that repeat biopsy, which underwent initial testing that the tumor biopsy had this KIT exon 11 mutation. And so he restarted the Sutent that he had tried before, but 2 months later, he had worsening disease. So all in all, if we speed this up, this gentleman then tried nilotinib, another one of those agents, didn't work, and he enrolled in a clinical trial and tried again imatinib plus immunotherapy. This drug here you see on the bottom called ipilimumab, but still had progressive disease and was actually referred to hospice in July of 2015. And he enrolled himself in August 2015. And so to sum up the case in brief here, we have this at the time, he's 48 years old at this time with a gastric GIST, and he has progressive disease now on 5 different medications: imatinib, sunitinib, regorafenib, pazopanib, and nilotinib. So he had a CTDNA analysis performed, which is that blood sample, liquid biopsy I was telling you about. And on that liquid biopsy, they determined, this is how it shows up to us in the office. When we send it out, the report comes back and shows this alteration burden or mutational analysis. And this gentleman had what we call an exon 17 resistance mutation. Previously, we were discussing primary mutations, and now we can talk about resistance mutations after being treated for some time. And this particular mutation confers some resistance to imatinib, meaning the imatinib drug in studies that have been shown not to be as effective. And so this is a scheme. It's kind of hard to understand, a little bit hard to read, but the colors here show that at the top, we see all the different drugs. This is a study from Spain, Dr. Serrano, that was published in 2019. And on the left here, we see all these different mutations in the different exons. And they just talked before me, the case about a patient with exon 18 mutation, but here's exon 13, 14, 17, 18. If we just take this alphabet soup of letters and numbers and look at the drugs here across the top, over time, these drugs in red have shown some resistance if the mutation on the left, if it's red, that indicates that the drug is resistant. Blue means the drug may be sensitive. White is rather unknown, and yellow has sort of an intermediate determination of whether or not these medications will or won't work and increase what we call in our world as progression-free survival. Sometimes you'll see it abbreviated as PFS. And so in our patient, he had this mutation, the orange arrow, the Y823 exon 17 mutation. So looking down this row of medications, we can understand why his imatinib wasn't working, this Sutent or the sunitinib wasn't working. And so going back to the case, he was actually started on a drug called ponatinib, which if we look back on this graph, that's the blue one here that shows some sensitivity in patients that have this exon 17 Y823 mutation. So he started on the ponatinib, and after 6 months, his disease in his liver actually shrunk significantly. Here's some scans that show before he started the ponatinib, this large liver lesion. And this is a CT scan showing his entire abdomen. He had another mass here. I don't know if you can see my mouse, but the lesion here. After 6 months on the ponatinib, you can see the liver mass significantly shrunk. After 12 months, it's stable in size, and we call this a durable response. And even 12 months after this scan that I have on this slide, the disease was still relatively stable. So this gentleman had about 2 years of progression-free survival on this drug ponatinib based off of his liquid biopsy, the CTDNA. So basically, I'm just supporting what everyone else today is going to say, and that we really value the use of these biomarker tests in sarcoma now, specifically with GIST. And hopefully more studies that are ongoing and research that we have can identify both the primary and these resistance mutations that can help guide the treatment planning and give optimal therapy options for patients with GIST by this liquid biopsy called CTDNA. That's rather quick, it's non-invasive, it's just like a regular lab test you would get when you get regular blood work at the doctor's office. And this can help us with ongoing research in the genetics behind sarcoma. And on the bottom here, there's actually an upcoming trial that we're hoping to start and enroll patients in here at the University of Miami in Sylvester, which is a phase 2 study of CTDNA guided therapy in patients with GIST, where the patients will actually, if they have an exon 13 mutation on the CTDNA, they'll be given Sutent or sunitinib, or an exon 17 mutation, and they'll be given regorafenib. And then we'll study the overall response rate in those patients, again, kind of using the CTDNA biomarker to help us. And so at the end, we'll take questions, but I just wanted to give a shout out and thank you to my mentors, Dr. Trent D'Amato and Dr. John Zek here at Sylvester. And again, thank you guys for the opportunity to join. This is an exciting webinar.
Thank you, Dr. Bialik, and we really appreciate you shedding light on a new tool called Circulating Tumor DNA to help with this testing process. And also, it was nice to learn that you guys are starting a trial to validate that screening more. So thanks for sharing that.
Yes, Dr. Trent gave me the okay to reveal it here.
Yeah, that was like a fresh, brand new reveal. So thank you.
Spoiler alert, yes.
Yeah. Okay, now it's Dr. Duran. You can begin your presentation.
All right, can you see that?
Yep, all good.
Perfect, thank you. So I'm Dr. Duran. I'm one of the hematology fellows at Vanderbilt Ingram Cancer Center down in Nashville, Tennessee. Sorry, I thought I would be in lab this morning, but we had our first snow in Nashville of the year. So the roads are a little hairy, so I'm coming from home today. But I just want to say thank you to the LifeRaft group for allowing me to give this presentation today. So what I wanted to talk about was wild type GIST, biomarker utility in rare subsets of GIST. So our patient today is Mr. WG. So he was, this was back around 2010. This is a 65-year-old gentleman, came to his primary care provider and had 3 months of iron deficiency anemia. It's something that we often see in someone that age. He had heartburn, weight loss, and some melena. So he had black and tarry stools. If I was a primary care provider and I saw somebody like this, I would immediately start to think maybe there's some sort of bleeding in the GI tract. Commonly, I would think about a peptic ulcer or maybe H. pylori, something that would be causing this. And my first step would be to send him for a study to try and determine that. So that's exactly what this primary care provider did. He was sent for an EGD, really long word, just to say where we're going. We'll go down the esophagus, into the stomach, into the duodenum, which is the first part of that, first part of the small intestine. They did their initial scope and actually found no problems. Unfortunately, the patient still continued to have some symptoms. So they did a capsule endoscopy, and that's rather than using a scope, you actually give somebody a pill that has a camera in it. And that goes all the way through their GI tract. And then a GI specialist can review those photos. And this study actually showed some fresh blood in the stomach, which was a little concerning. Definitely something that needs further follow-up. So they did a repeat of his EGD. And this time they pushed past the duodenum into the second portion of the small intestine called the jejunum, where they identified a mass and took a biopsy. So they took that biopsy and they sent it for some biomarker testing. They performed some immunohistochemistry, and we saw that it was positive for KIT and CD34, negative for SMA and S100. But really, this is consistent with a GIST. One thing I did really enjoy over the past couple of weeks getting ready for this, I was impressed with the resources that the LifeRaft group has on their website. I would encourage you all to review some of their web pages, because really it has a lot of good information. So you see KIT in 95% of cases, CD34 in 60 to 70% of cases, and then the markers kind of decrease from there. So the next thing, as somebody who now comes to a clinic with a GIST, if we're going to talk about what our next steps are, really I'm going to think about how am I going to risk classify this GIST. So this patient in particular had a 5.9 centimeter mass, which would fit into our TNM, or tumor node metastasis and grade staging, as a T3. Lymph nodes were negative. There was no signs of metastasis. After his specimen was resected, we looked at it under the microscope and saw that there are actually greater than 5 mitosis per 50 high power fields. Sometimes you'll see that as per 5 millimeters squared. Partially, it depends on the objective, the lens that person, the pathologist, is using to look under the microscope to be able to evaluate the rate of mitosis or cell division. It kind of gives you a marker of how active the tumor is. And if we follow our chart down, we actually see that this patient has a high metastasis rate potential, predicted biologic behavior for a higher metastatic rate at 85%. The patient, it's 2011, started on imatinib for adjuvant therapy at that time, with a plan to complete 3 years. Unfortunately, in 2013, there was a metastasis that was detected, and the patient underwent a biopsy, which showed an NF1 mutation. So I know we've talked a little bit today about some of the more common mutations that we see in GIST, but this patient had a mutation in a gene called neurofibromin 1, and not to try and get too much into the weeds here, but NF1 is part of it's actually a tumor suppressor gene. It's a protein that helps to put the brakes on some of our signaling pathways. In particular, this has been tied to the RAS-RAF pathway, which you can see down here. It has some more downstream signaling molecules, but overall, this is a pathway that promotes cell growth, survival, and proliferation. It's associated with a familial syndrome called neurofibromatosis type 1. And actually, 25% of patients with NF1 will develop GIST in their lifetime, something that we have started to recognize more and more. So we've already talked about some of the biomarkers. We've had a case on KIT, PDGFR alpha. That represents 85 to 90% of the GIST that we're going to see. Wild type GIST, we say wild type, just they don't contain mutations in KIT or PDGFR, is going to represent 10 to 15%. Most of those are going to be SDH, or sexonite dehydrogenase mutations. There's also going to be some that are BRAF mutated. Then there's going to be this other even smaller subset called quadruple wild type, which is going to represent 50% of wild type GIST and 5% of GIST overall. So how do we go about trying to dissect out a wild type GIST, and what does that mean? Well, what we're doing is we're looking for alternative driver mutations. Here, as has kind of been addressed before, we have NF1, NTRK, RAS, and FGR fusions, which might be the genes that are mutated that are now driving this particular cancer. And in our case, we actually found a frame shift in the NF1 gene that we believe was the driver for this patient's malignancy. So we've already kind of gone over it. I'll just quickly breeze through. That's the nice part about going third in something like this. We've already had some great background on what we're doing. So how do we assay this? A biomarker in a wild type GIST? We do the genetic sequencing. That's the NGS that you've heard about. Really using this expanded panel of genes to try and look at what's been shown through years of research, signaling pathways that contribute to all types of cancers, and what might be driving cancer for an individual patient. And as we just heard, you can either do this on blood or a tumor sent to an academic or non-academic laboratory. So what next, right? This is a lot of information. We have the super rare subset. It could be associated with a familial syndrome. What's my next move? And this can be overwhelming for a patient. This can also be overwhelming for a provider. But that's where we as an academic community, as a community that likes to provide the best care we can for our patients, we have experts that we can talk to as well. So appropriately, this patient was also sent for genetic counseling. So genetic counseling, it can either be an individual or a group of folks that get together. They're really going to do a thorough review of a patient history. They're going to do a thorough review of your family history. And really what the question is this a mutation that is germline or somatic? And does my family need testing as well? So what is a germline mutation? This is an example from actually a prostate cancer presentation, but I think it illustrates the point well. Or germline mutation, this is something that is kind of inborn. It's going to affect all cells, in the entire organism, and half of the gametes, half of what you are going to use to procreate is going to express that mutation as well, versus a somatic mutation. So somatic mutation is it's an insult that's happened after development. And really, you're only going to have a certain area that's involved. I think the easiest example for me to wrap my head around is lung cancer and cigarette smoking. We know that cigarette smoke can act as that stimulus to change around the cells within the respiratory tract that can sometimes lead to lung cancer. So that would be more of it can cause a mutation that would be somatic. That doesn't necessarily mean you could pass on to your children or to your family. So our patient, WG, he underwent his genetic testing. Thankfully, he was negative for NF1 mutation, kind of given some of his skin findings though, because neurofibromatosis type 1 can be associated with neurofibromas on your skin. He was recommended to have his family was recommended to have skin evaluations. But because we were able to do this germline testing, because he went to a genetic counselor, his family members didn't require invasive genetic testing themselves. So really, this is an interesting case because it's a rare presentation of an NF1 positive tumor in somebody that doesn't actually have neurofibromatosis type 1. And this would not have been found without advanced biomarker testing information. So a little bit more on his treatment timeline back to 2013. This patient, after the finding of NF1, decided that he wanted to try a clinical trial. So we had a phase 1 clinical trial that was available that included a STAT3 inhibitor. Now, STAT3 is another kind of downstream signaling molecule. And over here, the cartoon that I've chosen to represent most of this pathway, you don't even see STAT3 mentioned. It's one thing I'd like to say, as you do different research yourself, or as you use online resources, not all charts are going to be all encompassing, and sometimes you have to do a little bit of digging. So this trial actually was based on some preliminary data that was linking the RAS-RAF NF1 pathway into mTOR, and these are all just downstream signaling molecules that eventually wound up with STAT3 activation, leading to cell growth. So that was the rationale behind choosing this treatment. We have this rare subset. We know we have a signaling pathway. What can I do to target that pathway downstream of where the mutation is? So that patient was started on that inhibitor. Unfortunately, after two interval scans, we had progression, and that actually led us to to remove the metastatic disease. So his disease was focused solely in his liver. So we were able to take that out and actually provide some good break for treatment. So from 2014 to 2016, the patient didn't have any more therapy, but unfortunately we did have a recurrence in 2016. The patient was started on sunitinib, one of the drugs already mentioned today. The reason that we chose sunitinib is because, once again, with that NF1 mutation, we're really talking about this RAS-RAF pathway over here. And sunitinib is one that we can choose. This diagram is showing you multiple portions of the pathways that we know that are involved in GIST biology. And you can see where different drugs might hit that along the pathway. And sunitinib is one that hits it in multiple spots as you go down. So that was why this was a good choice in this particular patient. Unfortunately, after starting the sunitinib, we did have progression of disease again. And that at that time, the patient once again elected to pursue another clinical trial. And this time we used a drug called trametinib, and trametinib is actually something that blocks, it's an inhibitor of MEK, which is another downstream signaling molecule within this NF1 pathway, in hopes to try and turn off that signal that's leading to cell growth, survival, and proliferation. Unfortunately, as often happens in clinical trials, or as I should say sometimes happens in clinical trials, there was some toxicity associated with the medication. That's kind of one of the things I feel like is really a harmony between some of the basic science that we can develop to, to try and target these pathways, as well as actually taking patients into account. We have to design a drug that is tolerable as well as effective. So unfortunately, the patient experienced toxicity, was taken off the clinical trial, but then was started on another TKI. Once again, this is regorafenib, was mentioned earlier as well. This also targets part of that signaling cascade downstream from the RAS or from the NF1 mutation, to try and really eliminate that cell growth, survival, and proliferation signal. So the patient was started on regorafenib in 2016, had a prolonged partial response through 2019, and actually had a Y90, a localized treatment to that remaining liver metastasis. So that was in 2019, and then the patient was taken off therapy again. So we now have had 2 different treatment breaks within this decade of treatment for this patient, that I think really kind of shows how effective some of our therapies can be. Unfortunately, just this past year, had a recurrence in 2021, but started back on regorafenib and is doing well so far. So this is 10 years of different targeted therapies trying to hit different portions of his pathway to really treat this individual the best we can. This was all based on his biomarker information. So why do I think that biomarkers are important, especially in rare subsets of GIST, is that they're driving our treatment. What we can do even sometimes is use FDA-approved medications from other cancer types to look at a signaling cascade, to look at what might actually be the most applicable to an individual patient's tumor, and choose a medication that will hopefully target that. This patient had a great opportunity and bravely participated in 2 different clinical trials, which is something to be applauded, especially in such a rare subset where even today, if you look at the clinical trials that are available, there are very few that have wild type GIST in mind. Actually, one of the NF1 specific clinical trials had to close early because of slow accrual. They couldn't get enough patients in a meaningful time to be able to test out their medication. So it's really a tough situation for some of these, for a rare subset of a rare disease. The other thing that I, as a basic science researcher, really think about is biomarkers driving my science. So understanding which signaling pathways are important really helps target drug design experiments in the lab. So knowing, not only how these cascades, these signaling pathways have been put into place in other organisms, other disease types, really it helps me understand functional outcomes of these mutations and which ones are important for targeting, rather than blindly trying to find the right, or I should say a magic bullet. So the value of wild type biomarker testing wild type GIST, really it's guiding some treatment options for rare subsets of patients. It's giving knowledge and testing options for family members, especially in this case where there very well could have been a germline component. It's going to help us lead to further characterization of rare GIST subtypes. That's something that I'm very passionate about, is being able to take patient samples to try and sequence them out so that we have a better idea of kind of what these other boxes of tumors are, right? We have less than 5% of all GIST are presenting as quadruple negative. Quadruple wild type. How can we further characterize those to drive treatment for those patients in particular? And then also it's leading to scientific discovery, drug design specifically for GIST patients, and then guiding basic science insights. So just like to say thank you very much to the LifeRaft group for this opportunity to talk. I love that one of the wish list items is to find effective treatments for the rare subsets of GIST, something that I'm very passionate about. And then also to my clinical mentors, Vicki Keedy and Libby Davis, who have guided me through the sarcoma clinic and really inspired me to choose sarcoma as a specialty. And then to Dr. Ben Park, my basic science mentor, who's allowing me to work in his breast cancer lab to apply some of the genetic techniques that they use to sarcoma patients to really try and get to the bottom of some of this.
Excellent. Thank you so much, Dr. Duran. Excellent presentations all around. Also, thank you to checking out the LifeRaft Group website and the plug. We really appreciate that. So now we have entered the Q&A portion. So I'm going to start off with the first question that came in. How realistic is it for biomarker testing to take place in the most general oncology settings? Who would like to take that one on?
I think that, you know, from an academic standpoint, I understand, I think your question is in a more generalized oncology setting. The next-gen sequencing, both the tissue and the CTDNA, are relatively simple tests to order. I'm not sure, and maybe, I don't want to put you on the spot, but maybe Dr. Somaya, do you know if this is more easier to order in general practice? Because coming from an academic center, it's quite easy. We just put the order in, and it does sometimes take time. More so for the tissue-based than the CTDNA, but it is a rather simple concept.
Absolutely, happy to answer that. So actually, it is not difficult to order it in any community oncology setting, because, you know, they might not have their pathology lab linked to a place that can do targeted sequencing for KIT or PDGFR. However, they have access now to next-gen sequencing, which has become fairly common for other tumor types as well, including lung cancer, et cetera, which are very common. So it's not, people have access to it, your oncologists have access to it. It's just about thinking that it is important in this sarcoma as well, right? So it's just understanding the importance of it, because for a long time, the only thing we had around for initial treatment was imatinib, but we didn't have all these other new treatments, and people didn't know how to match these newer treatments to the mutations. But having access to mutation testing is there. But to your point, CTDNA is also, they have access to CTDNA testing, but I would say not every place has the expertise to figure out how to utilize that CTDNA test results. So that's where the academic centers can you know, come of use, or are, you know, it's extremely important to get a referral, or at least a second opinion at an academic center with expertise in GIST. But you can always ask your oncologist to send off mutations. You can always ask for a second opinion, even if it's a one-time opinion at an academic center, to make sure you're on track and that they've done the appropriate mutation testing.
And if I could just add one thing that I did notice on the LifeRaft website is they do have a section about molecular testing, and they provide non-academic laboratories that are available to help with the testing. And some of those laboratories do have patient support where you can contact them. They can get in contact with your provider to try and not only help get the testing done, but sometimes they can even alleviate some of the financial burden.
Thank you. Actually, I was going to ask about that in terms of what your experience is in terms of the cost of testing and the burden on the patients. Do you find this to be an issue in your practice?
So I can tackle that, because maybe I've been doing this for a little while now. But in terms of you know, testing reimbursement, so if you do just the targeted testing for KIT PDGFR, which is the upfront, you know, to detect if you have that, that's almost as part of pathology, and it is considered diagnostic. So if you have insurance, that part is covered. When you get to the next-gen sequencing or sending off the entire panel, it varies. I mean, even I don't have a head around which insurance covers what. A lot of times it is covered, at least the first NGS test that you send is covered. CTDNA also is similarly, it's very insurance dependent, whether it'll be covered or not. But just as Duran mentioned, Dr. Duran mentioned, is that you will have access to private you know, testing companies that provide very good patient assistance. So we've had companies that have assured us that patient costs would be minimal, nothing, or if at all, max of $100 if the insurance, they do bill the insurance, because they're of course trying to figure out if they can make money out of it. But if it is not, if they're not able to get it covered, they do have an assistance program that you fill out the form, and it's actually not very labor intensive, and they're pretty quick in letting you know whether it's covered. So I think, you'll have to explore it. I'm not saying it gets covered for everyone, but if you're being, if the company or when your doctors order the test, if they come back saying that you need to pay so much, then you can have this discussion again with the oncologist as to how important. Because normally, as I said, the front line or the first testing is always covered, or is majority of the time should be covered and can be fought and you can get it covered. It's the subsequent testing when you're doing sometimes, there's a little bit more back and forth. The oncologist has to do this peer-to-peer to try to get it proved and, create a justification of why we want it. So there you'd need more discussion with your oncologist.
Okay, so this person wanted to know, and this was in the MD Anderson presentation about the possible cognitive decline with treatment. They just wanted to have a bit more conversation on ways to avoid this or overcome it. And that may even also just be in general about other toxicities to anticipate when taking a new treatment or a trial.
Absolutely. So actually, there is there are reports with other TKIs as well, where patients can have cognitive defects or decline over time, and sometimes the mechanism of action is a little different. The key is to identify, right? The key is when you have a side effect, whether it be a cognitive decline or any change in your mentation, is to discuss with your provider, discuss with your caregiver, your provider, so that it can be evaluated. Sometimes it might not be related to the drug. Sometimes it might be related to the drug. Sometimes it is reversible, or you could figure out ways to counteract fatigue, counteract depression, things that could also lead to cognitive change. With the particular case we presented, with Avopritinib, it is a known risk where patients can have this mental slowing decline that can get progressive. So there, the only treatment so far is basically, I have had a great responses, rather to say, in decreasing that cognitive decline by catching it early and decreasing the dose. So sometimes you require dose interruption and then you come in with a lower dose, and that seems to, try to get to the lowest dose that is creating a response and also minimizing your cognitive decline. Again, it's a risk benefit. So sometimes, depending on how much benefit you're getting, you're willing to take some of that risk to try to get to that good outcome. But the good news is, even in that situation, if you stop the drug, it is eventually reversible. So the cognitive effect. And that goes with actually most of the side effects with these drugs. If you have a bad side effect, you stop it, it will reverse.
Great.
And then with dose adjustments, it can be corrected. Sorry.
Yeah, that was great. Thank you. So sometimes when you see a report, there could be multiple mutations or genes mentioned. As a provider, how do you know which one's the dominant one that's driving the disease? Anybody want to take that one?
I'll give the others a chance to speak, and then I'll.
Dr. Bialik, for instance, with circulating tumor DNA, you may have a whole bunch of different mutations that may be listed. How do you know which is the right one to target?
Exactly, and it's a great question. And in the case that I presented, actually, where we had the patient with the KIT exon 17 resistance mutation, the list actually on the CTDNA report sometimes actually shows FDA-approved drugs that are shown to be sensitive or can work with this particular mutation. And oftentimes I feel that it tends to relate to what the patient's already received in terms of what drugs that they may have already seen or been exposed to, and which lines of therapy they haven't yet had. And so if there is some drugs that are showing sensitivity to X mutation that they haven't yet received, that's a feasible option in hopes to get some disease control. But in terms of which one, I think it's more of a case-by-case basis based on the patient's particular mutations and what medications they've had and have had either response or toxicity to that they couldn't tolerate, and kind of going from there. Is that helpful?
Yeah, thank you.
And another great tool that some places have that I know that Vanderbilt has, we have a molecular tumor board. So not only is this a group of different oncologists and genetic counselors and subspecialists they can add to your cancer focus by saying exactly what you're asking, which is which of these are targetable, which ones are meaningful. Dr. Park, my research mentor, he leads our molecular tumor board. I know we have participants from outside Vanderbilt. We have community doctors from even the West Tennessee area that are often on our calls, as well as Mississippi, to present their patients. They get this complex NGS data, next-gen sequencing data back, and say, hey, what do we need to do with this? Is this meaningful? And it's really a great way to use experts to parse that apart, to say, hey, these ones are druggable, or they have, they have drugs that are available. And actually, often the recommendation of the molecular tumor board can help get those drugs approved for the patient through their insurance company. So it's definitely something to look into.
Great, thank you.
Just quickly to piggyback off what Dr. Duran's saying, and I think we've said this before, and it hammers in a good point that you mentioned about this sarcoma tumor board and the access of these multidisciplinary boards that we have at larger academic centers or high volume sarcoma centers. And so community practices are great, but I think Dr. Somaya said before, even a second opinion at a larger center, there have been studies that shown that high volume sarcoma centers have different data compared to smaller community practices because of the rarity of sarcomas in general and GIST. And I think I cut you off, Dr. Somaya. You were about to pop in and answer the question before this one.
You guys did excellent.
Okay, great. When somebody gets a report, and this is directed to Dr. Duran, because you in your case, you were looking to see if it was hereditary or somatic. Does that information come initially, or how would a patient have a conversation with their provider to see if like another lab needs to be used to test that information, or could it be the same lab? So that they can understand if this could be a hereditary form of disease.
Yeah, certainly there are, you can always go back to see from the lab tests. We know a lot of the times what we sent, right? So if you're sending a piece of tumor for sequencing, we're going to look at a panel that'll hopefully tell us, whether this is a somatic mutation or a germline mutation. Within the circulating tumor DNA field, from what I understand, the variant allele frequency will change kind of based on whether something has a higher percentage chance to be germline versus somatic. But it's definitely something that from my understanding, it does appear on these reports. I don't know if anybody else has something else to add.
Okay, thank you. This is a big question to ask. I don't know if you have the answer, but the whole reason why the LifeRaf group is having this is to really express how important it is for testing to be performed in the patient population. So I guess the question for you guys, this is a thought-provoking question, is why do so many GIST patients not receive biomarker testing? Do you have any thoughts behind that?
So, I can tackle that. The good news is that over the many years of my practice, I have seen far more patients receive biomarker testing in the community setting compared to before. So I think the word is getting out, and there is increasing use of biomarker testing. I mean, it is not anywhere close to where we would like it to be, but I think we're getting there. And seminars like this, or podcasts, or whatever that inform patients and providers the importance of this biomarker testing is what's going to make the difference. So I think it's really, ultimately GIST is a rare tumor. So if someone's in the community setting and hasn't seen many, their knowledge is based on when they first learned about GIST a few years ago, and might not have encountered a case after that. So of course, some of them would learn with the next case they see, and might go in and explore what's the new thing to do in GIST. But sometimes there is a lag because everyone's busy, and things get lost, and everyone knows you start imatinib, and that works. Majority of the times it works, right, for their patients 60 or 70% of the time. So why should the next time be any different? And this is why it gets missed. But I'm hoping that information will get out and that percentage will increase.
Yeah, it's hopeful and to hear that you're seeing more cases from the community get testing. And I just want to end with another plug that the LifeRef group actually has a testing initiative. So anybody who's listening today or will be hearing the recording, if you haven't gotten testing, definitely we want to refer you to one of these specialty centers like you have heard from today who do this testing. But we also, the LifeRef group, we have a testing initiative and it is providing free testing to patients. We've actually partnered with a laboratory called Tempus with this initiative. So if you want to learn any more information, feel free to contact the LifeRaf group. And I'd just like to thank all of our presenters today. I think each case really demonstrated the value of how important it is to get this testing done. It's encouraging that more testing is being done, both in the community and academic centers, but we still need to continue to share that message, and each of you did that today. So I want to thank you for putting the time and putting these presentations together. And it was also lovely to get to know all of you as well, because some of you are new faces in the GIST space, but we look forward to interacting with you more. And with that, I hope everybody has a lovely start to the new year. Stay safe and healthy. Be well.